see her? Do you? Okay. All right, so this week we're going to be talking about special populations and health policy. For you all who are in Dr. Mamudu's class, this is not nearly as comprehensive or anywhere near as in-depth as that class, but it is a good just introduction to thinking about health policy from this course and what we're kind of focused on. And of course, special populations are something that is key, very important for all of us working in health care and public health. So special populations all have something in common. What are something they have in common? From the context of public health or healthcare.
Some level of vulnerability.
Vulnerability, right. So they are at greater risk of poor health compared to the non-special, the rest of us, unspecial ones. So again, certain population groups are at greater risk. We often have multiple different terms to kind of that are used somewhat interchangeably: underserved, medically disadvantaged. But when we think of at risk of greater risk of poor health, this is health in that holistic. So it can be physical health, psychological health, social health, right? They have vulnerabilities around health. That's how we're talking about the special populations. And this is not an exhaustive list of special population groups, but they're the ones that we'll focus on today. Okay, so your book has this conceptual framework of vulnerability, and it's kind of hard to see on the slides because the print is small, but really I think it's important because it really is kind of showing this concept that vulnerability is the convergence of risk factors both at the individual and the ecological levels. So, and it refers to the likelihood of experiencing poor health or illness. And so we have these characteristics that are predisposing, enabling, and need characteristics of vulnerability. And for those of you who are familiar, these terms, predisposing, enabling, and need, are part of the Anderson framework of healthcare utilization. It's a very prominent framework, and we use it a lot in health services research. We're using it as part of some of the research we're doing around you may be familiar with the Choose Well evaluation. This is one of the underpinning frameworks. But when we look at our predisposing characteristics, these include both individual and ecological. And when we look at enabling, same thing, and need. So they're not only individual characteristics of the person, but also their environment. So what does the term predisposing mean? This pre. Before. Yeah, so these are the things that either increase or decrease your vulnerability. And so there's just a very small list of, and it's not exhaustive again, these are racial and ethnic characteristics, gender and age, where you live. These predispose you to your vulnerability. And these these things that predispose you, are these things that you can change? Can you be like, you're at risk, so we're going to change your age and make you younger? Or we're going to, your ethnic group is at higher risk, so why don't we just assign you a different ethnic group? These are things that are not malleable, really. You could move your geographic location, but that is not as a intervention. You can't just move all the rural people somewhere else and now you don't have the problem with that vulnerability. Your enabling are things that are areas where you can intervene. So insurance status, your homelessness or homed, and your need characteristics are more related directly to your health. So your mental health, any chronic disease or disability, and like HIV/AIDS status or some specific health condition. So all of these converge to equal your vulnerability. And then they impact your health outcomes, and again, like that. So you have your vulnerability. It is impacted directly by healthcare. We'll just call these healthcare. So access to care and the quality of care. And so based on that, there's an impact on your overall health, physical, mental, and social, at the individual level, and then when we think about population health, at the population level. Does this make sense? So we'll talk about those vulnerable individuals. We'll start with racial and ethnic minorities. So Black Americans are more likely to be economically disadvantaged than whites, and they fall behind on health status, despite progress that has been made. So we are in overall doing better, all Americans, all folks, but that is not something that is equally across different groups. Black Americans have a shorter life expectancy than whites. Our largest minority group and the fastest growing are Hispanic Americans. They are also one of the youngest groups in the United States. But due to relatively low education levels, Hispanic Americans have higher unemployment rates than non-Hispanic whites, and are more likely to be employed in semi-skilled or non-professional occupations. So we know that those types of jobs, what are they less likely to have? If you're unskilled or low-skilled, and the jobs you have are semi-skilled or unskilled.
Health insurance.
Yeah, health insurance. Those are not the jobs that have, the gold star health insurance or health insurance in general. What else?
Benefits,
yeah.
wages.
The benefits. So their economic status is lower, and economics are so strongly tied to health, education, all of it. Okay, so Asian Americans account for less than 6% of the U.S. population. This subpopulation includes 19 million individuals. The thing about Asian Americans is they're not just one people. They're not just from one country. Right? They're from multiple countries with different varying health, culture, all the things. Like we lump them together in the U.S. as Asian Americans. So it is a very diverse group, even though they're together. They're a very diverse group. So you have some subsets of Asian Americans that are doing better around education and income than other groups, than whites in some cases, and other minority groups, and then other populations that are not doing as well. And then the final group is American Indians and Alaskan Natives. So about 3/4 of Native Indians and Alaskan Native populations reside in areas outside of the reservations or off-reservation trust lands. So only 1/4 of this population live in their territories. So incidence and prevalence of certain disease conditions such as diabetes and hypertension, infant mortality, and chemical dependence are high in these groups. And they have, Native Americans have greater death rates related to alcoholism, tuberculosis, suicide, and homicide. Native women are at risk of homicide. They have a very high risk of homicide. Epidemic levels. And children. Native American children. So, some of the statistics. So, low birth weights are most common among Black Americans. And this is a statistic that holds differences even when you account for the social economic status, so education, income. The mortality, low birth weight and mortality, maternal mortality in Blacks are way higher than white women. White adults drink more alcohol compared to all others. So this is one of those areas where the majority has the risky health behavior. And then when we look at screening for mammography for women is greatest in white women and lowest in Hispanics. And we know that if there's a delay in screening, then if there is, so breast cancer rates are highest in white women. So white women have higher incidence of breast cancer. It happens to more white women. But Black women die from breast cancer at greater rates. And that is due, not in small part, in a large part, to screening. So if you catch breast cancer early, you have a really good likelihood of curing it. But if you catch it late, mortality increases. Okay, so this kind of shows you over the years some trends. So we have some trend data on the next couple slides. So this is showing us U.S. live births weighing less than 2,500 grams by mother's race. And so babies less than 2,500 grams are considered low birth weight babies. And so you can see this is very different, right? You can see there's some, what do we see just in general that's going on? Are we trending up or down?
Trending up overall,
Yeah.
except for blacks. It's
Yeah.
a slight down.
Slight down, but still, in some cases, almost double other groups. So they're kind of black mothers. There's not really a distinct trend, other than bad. But for other groups, including whites, have been pretty stagnant the past 4 years. The last two groups, but there's this slight trend upward. This is not the way you want to see trends around something like low birth weight going, especially in a country that spends so much on healthcare. Okay, so here we're looking at alcohol consumption by persons. These are only 18 and older, so they're not necessarily of age, but they're not adolescents. These are young adults and older. Consumption of alcohol seems to be going up for most groups, except for American Indian and Alaskan Natives. But whites now are greater than American Indians in 1997. So higher levels of consumption. And then here is life expectancy. Now, this data are not, excuse me, do not show the most current trend of lower life expectancies, because the data are not new enough to see some of those trends. But who live longer lives?
White females.
Mm-hmm. Followed by
Black females.
black females. And then a similar trend of white and black for men. So white men live longer than black men. But women, we will outlive you all, men. Okay. Any questions about minorities, ethnic and racial minorities? It's probably not new information to you all. And this shouldn't be either. Those who are uninsured tend to be less educated and poorer. They work part-time jobs or employed in small firms. Why is this small firms part important from an ACA perspective?
They don't have to provide health insurance.
Right. So if you have less than 50 employees, they were exempt from having to provide health insurance or pay the penalty. So, and are younger. And so there's this misconception that uninsured people don't work. That they're all people who are just not working. But quite a few are working, but it's the types of jobs that they're working. Either their employer doesn't offer or they do not qualify. A lot of jobs that are semi-skilled or low paying keep individuals right under the hours that need to be covered by insurance. I mean, this happened to me when I was a student and I was working at a grocery store that provided health insurance. They would keep my hours right below what would qualify me as full-time. And it was like a metric, like you could work up to 40, but not for more than 2 weeks in a row. So like it was just this game of ensuring that I stayed uninsured. And we did not at that time have this 26-year-old on your parents' health insurance option. So it was critical, right, for individuals to have insurance, and they just would play that game. So the uninsured rate went down due to the Affordable Care Act. But as we've talked about in the past, there will always be uninsured, even if we had universal health care, because there are some people that don't meet the eligibility criteria of being a U.S. citizen or a green card holder or whatever. There are populations in our country, no matter what, that would not qualify to be covered. Excuse me. So children are considered a vulnerable population or special population for a variety of reasons. They're developmentally vulnerable. So the rapid and cumulative physical and emotional changes that characterize childhood, and those have a potential to impact the illness, injury, or disruptive family kind of pieces and social circumstances. So those have a major impact on children's life course. So what do we call bad things that happen to kids?
Adverse childhood experience.
Yeah, adverse childhood experiences. And if we were to ask questions to all of us in the room, I would suspect all of us have a few adverse childhood experiences. It's that accumulation of multiple adverse childhood experiences along with a lack of resiliency or support that really can impact their life, and that's what the research shows. There's also the issue of dependency. Children don't have a lot of control in their lives. They're at the will of adults for a lot of their decisions around their care. So there are approximately 74 million children under 18 living in the United States, which is just under a quarter of the population. And 21%, or 15.5 million, live in household incomes below the poverty rate. So over 20% of children are living in poverty. Children, though, are the most ethnically and racially diverse subset of the population. And that will continue to increase. And so, but we're seeing things happening in children that we used to think were adult diseases. So obesity, type 2 diabetes, other kind of chronic illnesses that again were not things that we saw. Now, are children more or less likely to be insured than adults? More. Yeah, so there are more programs and more generous programs for children than there are for adults as far as government insurance, such as CHIP, the Children's Health Insurance Plan. Okay, so females account for a little bit over half the population in the U.S. And we've talked in the past about them being like a very important consumer of health care, which is why we have women's centers and things like that. Women do live longer than men, but we do see greater morbidity and poor health outcomes. So women might live longer, but we might be less healthy. So that's the other side of the coin. We're going to outlive you, but we might be sicker. What surprises some people is that heart disease and stroke account for a higher percent of deaths in women than in men at all stages of life. We think of those as men's diseases, but that's not true when you look at it. And then some things about men, though. Men are more likely than women to report binge drinking. Almost 30% of men binge drink compared to 17% of women. In one day at least once in the past year. So that's like the qualifier. So in a question, have you binge drank at least one day in the last year? 30% of men have, 17% of women. Some other stats about women. They account for approximately half of HIV/AIDS cases worldwide. Women are more likely to be depressed than men. And then are at substantially greater risk of Alzheimer's than men. So again, we might be living longer, but we might be sicker in that life. Then here's just some additional information that we've talked about before, like about women and their use of healthcare. So until the age group of 65 and older, women have higher physician utilization rates than men. So what happens at 65? Medicare, yeah. So now it's covered, and so that somehow triggers that differential to change. There's not difference in hospitalization. So the things that do impact women around the healthcare system, though, is that they're in a distinct disadvantage to obtaining employer-based health insurance. So that employer-based, really good health insurance is harder to obtain as a woman. And that's due to kind of disruptions in their work history. So women are more likely to work part-time, to receive lower wages. There's a wage gap between men and women, and have those interrupted work histories. What is something that interrupts women's work history?
Children.
Yeah, children. Yeah, it's not just the children, it's the children and the child care. Child care in the U.S. is, for the most part, a luxury. Quality child care is a luxury. And so for many families, the math is just not there. If you have multiple children, to pay for them to be in child care compared to that already lower wage that the woman in the family might be making. So, and then because of that, there's a greater reliance on Medicaid for their health insurance. Okay, so rural health, we spent some time earlier in this semester talking about rural health. Rural citizens have poor access to health care due to poverty, geography or distance, topography, weather, availability of healthcare and transportation. So those things all impact access. Across all races and ethnicities, rural residents have lower insurance coverage. The ratio of providers to population is greater, so there's fewer providers to population. And as we've talked about, those rural hospitals as well, are those critical access hospitals. There's been quite a few closures just due to the financial strains. And though you may have a hospital, they don't provide the same scope of services. But we have these programs that are meant to improve the health of people in rural communities. So the first one is the National Health Services Corps. And this is, and many of you mentioned this when you're talking about some of the ways to improve the maldistribution of providers by geography. So these are scholarships and loan repayment programs that are really pretty good programs if you have the ability or are willing to serve a minimum of 2 years in an underserved area. You can get your loans repaid, and we know that med school is not cheap. So since the 70s, 27,000 people have been placed in medically underserved communities. Health professional shortage areas, or HPSA, are a federal designation indicating an area that has a shortage of primary medical care, dental, or mental health providers. They can be urban or rural in nature. But the area has to have, it's the ratio that's important. So for a primary care physician, it's a 3,500 to 1 full-time equivalent provider. So there are 3 different types. So the geographical areas, population, or medical facilities. A medically underserved area is an index of medical underservice that was developed to target community health centers and rural health clinics. So the index of medically underservice was developed, and it has 4 variables. So one is percentage of population below poverty level, the percentage of population 65 and older. That gets at the older population. Infant mortality rates, which is a metric of the younger population, and then the number of primary care providers per 1,000 population. All right, and that's pretty much what's on that side. So those distinctions help, like if you're in a medically underserved area, then community health centers and rural health centers can be established there and get funding to provide services to this community. So community and migrant health centers provide services to low-income populations. They have a sliding scale fee based on income, and minorities are their highest users of their services. And so these must be located in an MUA, or medically underserved area. And again, they provide primary care and preventative care, so not specialty care, and it can be hard to attract physicians, as we know, for multiple reasons, to these areas. And then the Rural Health Center Act authorizes Medicare and Medicaid reimbursements for services of non-physician providers. And this is really interesting because this allows these non-physician providers, so this includes who? What are non-physician providers?
Nurse practitioners and PAs.
Yeah, nurse practitioners, PAs, certified nurse midwives, to practice without direct supervision of a physician. So that allows them to practice at what we call the top of their licensure, which a lot of these providers like to do. I mean, they like to provide these like more high-level services. But it's interesting, so that they do not reimburse, they do not bill, but the centers bill for their services. So that, I think, how they get around those higher reimbursement rates, or the ability to reimburse for non-physician providers that are not under the care. Different states are addressing these kind of rural health issues by increasing the number of non-physician providers that a physician can supervise. So that can increase because there's these stipulations around how many non-physicians, nurse practitioners, PAs that a physician can supervise, and then kind of how far away they can be physically from them. So by changing some of those ratios can really increase access for rural communities. Excuse me. Okay. So there are about 3.5 million people without homes in the U.S. And some of these statistics are pretty, I don't know if you call them startling, but they're kind of difficult to think about. You know, we think of a homeless person, I think a lot of us, as a male, which make up 43%. But 40% almost are children under 18 that do not have a home. So when we talk about adverse childhood experiences, homeless is probably going to be one of those experiences and increase exposure to more adverse childhood experiences. And it sure makes things like education hard, right? Like, it's hard to think about school when you have a lot more going on. So it's just like this, it helps that just continue that cycle of poverty. And 36% are families with children. And this creates a lot of barriers to care. So if you don't have a home, there's some barriers to ambulatory services, so those ones that are community-based. Issues around transportation, just competing needs, like your basic immediate need is shelter and food and money. Next is your health care and your health. We have to meet those basic needs before we can help people. And because health and healthcare fall way low on individuals' priority list when they're homeless, we see higher hospitalization rates. Why? Basic reason for that.
Because they don't have access to primary care.
Yeah,
so-
they're not getting the ambulatory services. So they're not doing primary and prevention. So any issue will be, you'll delay care until you can't delay it any longer. Who makes up a large proportion of our homeless? Our portion. So 14% of our homeless are veterans. But there are specific programs around homeless veterans that the VA provides. And we live in an area that has a really good VA for that kind of stuff. Okay, we have just a couple more groups, and then we'll take a break before we switch topics. Mental health. And I think a few of you in this class were interested in mental health as a topic for your papers. So 1 in 5 Americans have a mental disorder in any given year. And so mental disorders are common psychiatric illnesses affecting adults, and they present a very serious public health problem. It's one of the leading causes of disability in the U.S. Suicide is the 11th leading cause of death in the U.S., and it is a preventable cause of death. And the 4th leading cause of people between 18 and 65. So there are barriers to care. The cost of services for mental health are not always covered in traditional health insurance. And then there's a shortage of mental health professionals. So if you have an area that is a medically, is a health professional shortage area, or you have a shortage of providers in general, you're going to have a shortage of these more specialized behavioral health or mental health providers. Interesting, Medicaid is the single largest payer for mental health. But and then when we think about the substance abuse, opioid epidemic, it's very hard there's a lot of morbidity between substance abuse and mental health. So, those are two things that need to be handled simultaneously to have the biggest impact. We've talked before, 3/4 or 75% of the total cost for medical expenditures around chronic disease. And chronic diseases are the leading causes of death in the U.S., with heart disease, cancer, stroke accounting for more than half of the deaths in the U.S. each year. And so it accounts for that medical expenditure, but it also has a large cost to our economy in general. Just thinking about loss of productivity, loss of mobility, things that lead to people not being able to be fully part of society. So HIV and AIDS, some of the major risk factors are male-to-male sex encounters, male-to-female sexual contact, injection drug use, blood product exposure, and then mother-to-infant perinatal transmission. So it's the sixth leading cause of death among people 25 to 44. And we have almost 450,000 people living with AIDS. And care is very expensive. We've made some really amazing advancements in taking HIV/AIDS from a acute, still called it acute in the name, but disease to being a chronic illness for many people. But it is a very expensive illness to treat. There are the Ryan White Care Act, though, is one of the main programs for treatment of HIV and AIDS. So it's money for treatment and care options. And so this is how do communities get this money? What is it based on? Like the amount of money a community gets.
Amount of need.
Yeah, so this is one that's like a formulary. So communities with greater need get more money for it. So when we look at how much we're spending, in 2016, over 60% was for care and treatment. Smaller amounts go to global. So this is for the treatment of HIV/AIDS internationally in a global perspective. And then very, 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 very small amount goes to prevention. So we can see when we think about the public health perspective that this is one of those unbalanced pictures. We'd like to see more prevention. And there are rapid HIV tests that can be done to find out status. You can take, for people who are at risk, high risk, you can take prophylactic medication to decrease your likelihood of transmitting the disease or becoming infected. So there's a lot of things that we can do to decrease the rates. Okay, any questions on vulnerable populations? All right, so we'll take about 5 minutes and we'll come back and talk about health policy. All right, so for our online students, make sure you watch the two I'm Just a Bill videos. The first one is the traditional one that you probably saw in elementary school and know and love. The second one was a tongue-in-cheek one back from the previous administration about the role of executive orders. So we'll talk a lot about health policy, but we won't really touch on executive orders and kind of how they play kind of a non-traditional, they don't go through the same routes. Depending on who's in the White House, the other party hates executive orders. But then the party in power seems to forget how much they hated them previously. So they are a way that is increasingly being used by presidents. Presidents on both sides of the aisle are very frustrated with the process, the partisan process. It's very hard to get things done now. We don't see a lot of what would be termed moderates on either side. So not a lot of across the aisle work. But we'll just keep most of the politics out of this health policy discussion today. So just some framing. Public policies are authoritative decisions made in the legislative, executive, or judicial branches of government, and we'll talk about how all the different branches take part in the policy-making process. And health policy is just this overarching term for principles, either stated or unstated, that relate to the distribution of resources or services that impact the health of population. And so kind of that tongue-in-cheek piece that we just watched, the danger is that policymaking often becomes highly politicized and is held hostage to the ideologies of the political party that happens to be in power at the time. So all of this is in this context that the party in power exerts a considerable peer pressure on its own members to support policies along party lines. Areas where it gets a little bit fuzzy, when I put up that resource around the repeal of the Affordable Care Act, some of the background information, and that at the beginning of that table that kind of discussed all the different parts were that for those for the midterm election, this past one, the number one topic, the most important topic in exit polls, what was it? Was it immigration? Healthcare. You'd think it was immigration, based on how much noise there is around it. But healthcare was the most important topic for voters. So this is one area where you do see some pushback, some moderations on both sides, because it is such a universally important topic. So health policies are a byproduct of public social policies that are enacted by and pertain to healthcare at all levels. And so this is policies affecting the production, provision, and financing of healthcare services. And so here are some examples of different kinds of policies. They can be, seminal policies like the Medicaid Enactment Act in 1965, to kind of more incremental changes that we see with banning of smoking in public places. Now that is not a national, but we've seen that roll out in jurisdictions, and then all the way up to states, so that it starts incremental. Health policies may be used as regulatory tools. So that would mean that they call on the government to prescribe or control the behavior of a target group by monitoring the group and imposing sanctions if they fail to comply. So what are some examples of a regulatory health policy? So they regulate groups.
State vaccination policy for public schools.
Okay, so something that like vaccination requirements for school-age children. That's a good one. We think a lot from the environmental sector is really one that we see a lot of regulation. So Clean Air Acts, different requirements for water safety, water waste, drug safety is a big one. So you see regulation as a tool around health policy, often for industry type things, where we don't, there's the tension between regulation and independence for productivity of industry. And so, you know, you've seen deregulation. We hear a lot about deregulation now. Traditionally, Republicans are more in favor of deregulation, allowing industry to regulate itself more so than the government come in. And then the counter is the Democrats. Also, we see regulation, and something that will be important for you all who are thinking of going to into healthcare facilities, is the licensure and certification of facilities. That's another regulatory policy. They can also be used as allocative tools. And so we think of this as direct provision of income, services, or goods to certain groups and individuals. So allocating services, income, certain things to certain individuals or institutions. So what are some of those?
Wouldn't like Medicare and Medicaid fall under that?
Mm-hmm. And so what kind, would that be distributive or redistributive?
It's redistributed.
Yeah, redistributive. So that takes money or power from one group and gives it to another. So we see money from the government, which is collected by taxes and other ways, but primarily taxes, given to a different group. But distributive policies are often things we think of as distributive are funding for medical research. So NIH funding, development of medical personnel. So thinking of the residency programs as being distributive. Things around construction of facilities or initiation of new institutions. So do those two make sense? Regulatory are things that are, again, related to controlling or prescribing the type of behavior, and fines and fees are one of the ways of taking, instead of allocating resources, taking away if you aren't following the behaviors. And then allocative are the ones that provide services, and it can either be distributive or redistributive. So there's the principal features of health policy in the U.S. Really, this is, you don't even have to have the word health in there. These are the features of the U.S. policy. And we're not going to really go into these in too depth. But, I mean, we see this every day. And when we hear just all there's a lot of focus on policy now. It's fragmented, it's incremental, it's piecemeal. The federalist setup of our government, where states have a role in pretty much anything that is not covered by the Constitution, those go to the state. So then we see these differentials and things going on at the states. We see this very clearly from a expansion of Medicaid, for example, versus expansion. We see it with policies around certain things like abortion, marijuana. What else? There's some hot topics. There's pretty hot.
Right to die.
Right to die. Yeah. And those are things that states are weighing in on based on their populations and the people that live within their borders, and they're making changes. And then the impact of the presidential leadership. I mean, we can see that directly. Part of the reason the midterm election happened for President Obama, that swung from having a majority in both the House and Senate, was directly related to health care. And we've seen that continue with every single one of the presidential candidates on the Republican side saying repeal and replace. And that played a big role in why people wanted President Trump. So their role is very big. The principal features, so we see that government spending on healthcare fills in private sector gaps. So we see interventions happening when the private sector cannot or does not provide the spending, or is not able to regulate itself, for example. So environmental protection, things like communicable disease, care for special groups, medical care for indigent. All of these are areas where the government spending fills in the healthcare gap. The most cited problems with government involvement in healthcare, and these are the reasons why when we think about, when we go back to week 1 of this course, when we were like, could America have universal health care, a universal healthcare system? These are the things that make people be on the fence or be totally against it, because these are the things we see as problems cited associated with the government involvement in healthcare. So there are health policy outcomes result from compromises to satisfy demands. And those who are included are the legislative committees, the executive branch, and private interest groups. So all of these are coming together and have often competing demands. So really, to have a policy outcome result, so that bill becoming a law, it takes a lot of compromise. And if any of you turned on the TV to any of the 24-hour news stations, you would see that is we're in a difficult place for compromise. But really, two of these communities, the legislative and executive branch, supply policies that are demanded by interest groups. And not to be surprised, or you shouldn't be surprised, but the well-organized interest groups are the most effective demanders of policy. So who from the healthcare realm, what are some of those advocacy or interest groups that you can think of? And we've talked about them at different times in the semester, thinking about groups that were either for or against certain policies, procedures.
The AMA.
The AMA, so the American Medical Association, huge one. Who else?
I mean, the AARP kind of, like, 'cause
Not
they're-
kind of.
Well, I mean, like, yeah, just because, like, they're not, like, totally in, like, healthcare, but, like, definitely, like,
Yeah, they have become a very effective demander of policies. That's one of the reasons you do not see a lot of changes to what two programs?
Social Security.
Social Security and,
Medicare.
yeah, Medicare.
Medicare.
They are very organized, and they are not only organized, they are very reliable voters. So younger people are not as reliable, but older Americans so are more reliable. They'll come out for every election. So that can be in your favor or not, depending on which end you lie on those things. Others are the American Hospital Association, Pharmaceutical Research and Manufacturers of America, as well. One of the things from a public health perspective, the American Public Health Association does not rise anywhere near the top of the most organized or effective demanders. So we do not see public health at this table as these other groups. Okay, so we mentioned the role that individual states take, and so this can be, when it comes to health policy, it comes into financial support and care for poor and chronically disabled. We see this in the expansion of Medicaid, as well as S-CHIP programs. Definitely the role around quality assurance and oversight of healthcare practitioners and providers. The state is that regulatory tool for those facilities and providers. Regulation around healthcare costs and insurance carriers. We've seen that with who can provide insurance in different states and what are the kind of qualifications or requirements. And then when we think about authorization to local government, of local government health services, this is what we call police power. So the states essentially giving over their right to govern to the local level. So taking away some of the power of the state, because there's no power given to anyone other than the federal government and states in the Constitution. But many states give authorization to local governments to do many of their activities. So here's just a history of some of the highlights or lowlights, depending on how you feel. So do we still have ACA? Yeah. It's continuing to change and lose some of its parts, but we still have it. So that executive order to repeal ACA did not come into effect. So making of any policy, but it seems particularly right now, health policy is complex. It involves both the public and the private sector. When we think about that relationship between the government and the private sector, where does that play into when we think about health policy?
The insurance market.
Yeah, the insurance market is one.
Kind of who's providing and who's the consumer, who's consuming it.
Right. So we have, even though we have most of our, so our largest insurer is who? Yeah, the government. But our providers are not government.
Private.
They're private. So that is this dynamic. So you have this relationship between the two. So it's not as easy as having, we can think of it on small scale as having physicians be salaried employees at the hospital. So at that level, the hospital or the health system has a lot more control over the behaviors of the providers. That would be what it would look like if the providers were government employees, or and same for insurance. It's not government run; it's privately run. So we'll just quickly discuss the 5 steps of the policy cycle. So the first step, and you kind of saw this in the I'm Just a Bill. So those people back at home thought of an idea, thought it was important. So that was really the issue raising. So that's the evaluation of a problem requiring a policy decision. So not all issues require a policy decision. It's only those that, again, the government will need to intervene for some reason. After you've kind of identified an issue, then the design phase happens. And so that's really the development of the policy proposal. Seeking the public support. This can come from interest groups. You might see, when the repeal and replace movement was happening shortly after the beginning of President Trump's term, you saw him going out to communities and trying to build support around the idea of repeal and replace. We see this a lot. So seeking the support, trying to navigate, especially in health policy, with those private sector interest groups. Then there's the legislative making, where you're policy support building. So that is getting support from key legislators and the hearings that accompany those. So you're trying to build consensus, trying to get enough people to support your plan, for example. And then the hearing phase is to really generate more information from experts. And then the implementation piece. So that requires, so after you do the support building, that's when you decide, and typically things do not go up for a vote. What 2 instances do things go up for a vote? So when you think about So, do we like to look like losers in general as people? So typically, things go up for a vote if what?
It has a good chance of passing.
Has a good chance of passing. The optics of not having enough support for something that you've spent all the time doing these other steps is not good. What is the other time that you may want to put something up for a vote that you know that won't get passed?
When the public's in support.
When the public's in support. What specific public?
Voting.
The voting or your constituents. So say we see this, especially in our work around women's reproductive health rights. We see this come up in state legislatures. We're seeing a lot of what might be categorized as heartbeat bills around abortion. More surprisingly now, for some of us in this area, is that those are passing legislations. But those things like that, where they don't necessarily have a chance. Even if they pass, the courts will get involved and they won't be implemented. But those are, again, to be able to either show your support for something, or on the other hand, show that someone else is not supporting it. So you might bring something up that is just has no chance of passing, but so that you can have the optics of being able to say, Senator Joe Smith is in favor of whatever. So there's a lot around that, but most of the time this goes to vote, then the president's signature, rulemaking, and then really one of the most important pieces that we sometimes forget is the allocation of resources. So that is another place where policy making happens. So something can be law, or like the Affordable Care Act, but if resources are not allocated for it, then it's not going to have the same impact. And we see this in ways around shortening the enrollment time for the marketplaces, lessening the funds to go to states to pay for people to help individuals navigate the insurance marketplace, around advertising. So you can use your money or lack of money to also impact policies. So there are legislative committees and subcommittees that are important for this process. So there are three important powers that Congress holds. The power to make all laws which shall be necessary and proper to carry out into execution. So really they are considered the lawmaking branch. They also have the power to tax and the power to spend. So they are what we call they have the power of the purse. They have the money. And we've seen this tension between the executive branch and the legislative branch around this piece around budgets a lot lately. Not the ones that come to mind that are really big right now are not necessarily health policy, but we see like the immigration piece, the funding of the wall, for example. Those are where the legislative branch has a lot of power. There's very interesting things that the president tried to do, and was he successful around an executive order recently? around an emergency order around the border.
Yeah.
So the president put out an executive order. One way that the president can get around the budget and the legislator is states of emergency, because there are certain times where the legislative process is too slow. If there is an emergency, a man-made or a natural, we can't wait for the subcommittees to vote on it and then the House and the Senate. So very creatively, the president said there was a state of emergency at the border, and therefore he was going to free up funds to use to help lessen that emergency. And this was the one case that a veto is his first veto, and around the funds around the border. So, there are ways around the purse strings, but that's really their major power. So there are 3 House committees and 2 Senate committees that are very involved in legislating health policy. So the Ways and Means Committee has the sole jurisdiction over Medicare Part A, Social Security, unemployment compensation, public welfare, and healthcare reform. So that is a very important committee, and you see that committee. So when the House or any chamber flips parties, then the chair of these committees switch. So the chair of the committee is part of the majority party. So these chair positions are really hot, especially around because these are really influential committees. So Ways and Means Committee, Energy and Commerce has jurisdiction over Medicaid, Medicare B, certain matters around public health, mental health, and healthcare professionals, as well as things really related to commerce. So food and drug, consumer protection, health protection, biomedical research. And then the Committee on Appropriations is responsible for funding substantive legislative provision. So that, again, of the legislative branch, this is the committee that does a lot around like how much money goes to different things. And on the Senate side, we have the Committee on Labor and Human Resources, which is over most health bills, and then the Committee on Finance, which relates to taxes and revenues. So as an extension of taxes and revenues, Social Security, Medicare, Medicaid, and then things around maternal and child health. So, if you're listening to, if you are a policy wonk or really interested in policy making, start listening and you'll hear these committees and be like, oh yeah, that's the one. Oh, so and so is in charge of that one. Okay. Are you guys policy people? Well, I know political science. You should be. I mean, a lot of what we do in healthcare and public health is so just at its core related to government, which is related to policy. And it's not just the federal side. I mean, with any change in an administration, like we've had with a new governor, then that leads to changes in his whole executive branch. So we have a new Commissioner of Health, all of which not only does the commissioner change, but then the people right under that person too. So there's a lot of change happening in public health in Tennessee right now. We actually have colleagues who are advocating for public health organizations today with the new Commissioner of Health, because you have to when there's new administration, you've got to establish those relationships over again. And our last commissioner used to be in Southwest Virginia. He has a house in Abingdon. So he knew ETSU. He knew the College of Public Health. So now we have to build those relationships again. And then it's all the way down to the very, very local level. School boards, all of that. Okay. So we're almost done. Okay, when we talk about access to care, so there are two arguments that we hear around, there's two kind of levels. So we have multiple policies that have been enacted to provide access to health care to specific groups that are otherwise unable to pay. And so these individuals will look very similar. So they are connected to the first part, the special populations. So elderly, what policies cover elderly? Access to care. Birthday girl. Starts with an M.
Medicare?
Mm-hmm. Medicare. Poor children. What covers poor children?
Okay.
Medicaid. And, did I hear the other one? CHIP. Mm-hmm. Poor adults.
Okay.
Medicaid, yeah. And then there's some local and state assistance. Veterans. Who cares for veterans? VA. We have policies around persons with disabilities. Lots of different ones. ADA is like one that we really think about. Equal access for education for children with disabilities. Who is kind of the agency for American Native populations?
Indian Health Services.
Indian Health Services, yeah. And then there are people who are covered with certain diseases. So end-stage renal disease, which is one of those it seems random additions to Medicaid, right? Which pays for kidney dialysis and transplants. These are very expensive treatments. They are bankrupting kind of treatments, but really critical for people with renal disease. So that sometimes I'll see if I can find the article that kind of talks about the history of that. If we haven't, did we put that up already? The article on the history of why renal disease is covered? Maybe not. Okay. Okay. So, there's really two arguments. So that citizens have the right to the same level of care, or citizens have the right to the same minimum level of care. Those two kind of have some really different implications in how you read them. And so we've already talked really about access for these different groups already in the previous part. So when we look at kind of the cost of care, so access because we have the three: access, cost, and quality, right? So we have the things that relate to access that we just listed. Related to the cost, the National Health Planning and Resources Development Act of 1974 really transition, kind of like refocus from just improvement of access to cost containment, kind of over access. And that has been the principal theme when we think about federal health policy is cost containment, which makes sense when we think of how much money we spend on health care in the U.S. and how much the government spends through Medicaid and Medicare and other programs that provide access. It's always looking for ways to contain cost. And then that third arm around quality of care. So the creation of the Healthcare Research and Quality, the Agency for Healthcare Research and Quality, AHRQ, and some people call it ARC, which gets confusing because we have ARC, which some people call ARC in Appalachia. So AHRQ, and so that in 1989, the creation really mandated this look at outcomes and effectiveness and appropriateness of healthcare services. And so they have funding for patient outcome research teams, reports, that really look at these really core quality measures of effectiveness, development of guidelines, and dissemination. Now, when you compare AHRQ's budget to the National Institutes of Health, it is very, very small. They don't have a lot of money, and they've actually cut their budget. And so there's not a ton of money to do this work, but there is some around that. And then really looking at quality, the seminal IOM report, Crossing the Quality Chasm, which found that more people were dying from medical error than in car accidents, which I think was one of those things that when you think about that, the court just seems really incredible. But they, the IOM in this report identified 6 areas of quality improvement. Patients should be safe in a healthcare facility, should be as safe in that facility as your home. So when you go to a hospital or healthcare facility, you should expect to be just as safe as if you were at home. Effectiveness, so that the healthcare system should avoid overuse of ineffective care or the inverse, underuse of effective care. So you want effective care being used and waste and to not be in the system. It should be patient-centered. So we think of that around, I think someone was asking Mr. Youngblood about his cake thing. So it's patient's choice. If they want all the cake, at some point you have to give them the cake. They have personal will, their culture, any social context. So really the special needs of the patient should be incorporated into the delivery of services. Timeliness, and we see timeliness a lot. Any healthcare facility can tell you their wait times, because that is one of those key measures of quality. Wait times and delays should be reduced. Efficiency, so always trying to reduce the total cost by getting rid of waste. And then equity, so that care is not different for different individuals. So those of us who are researchers who do policy level research, we can influence policymakers on multiple levels. What we do know is that policies are not based on the best evidence. It's just how it is. But we can do things to work on really strong research, and not only does the research need to be strong, but the dissemination. No policymaker has time for my 10-page paper with all my jargon in it and all my tables. You need to be as clear and succinct as possible and use as many stories as possible, because that will increase the likelihood of someone listening to you. Black and white, two-sided, 10-page paper will not be read even by those nice interns. It'll go straight into the trash can. So we are criticized globally as being the only industrialized nation that doesn't have universal health care. Don't see that changing anytime soon, do you guys? No. And then when we think about state reform, when we think about health policy and health improvement activities at the state level, those are those core functions of public health: assessment, assurance, and policy development. And so just a little bit of background. So in the 80s, President Reagan really was key in kind of ushering this return to control and discretion of healthcare to the states. Again, moving things from the federal government back into the states. And so we saw block grants as a way to consolidate lumps of sums that are distributed by formula base. So Ryan White Act funds are on that formula base. And so this gives states more flexibility. Okay, so just the final thing is some areas of concern that impact policy, health policy. So one of the reasons that we see such a high cost to our system is the medical malpractice. So just the litigious nature of Americans. And so because of that, that costs the providers quite a bit of money. And then as we talked earlier, mental health benefits are not typically they're not covered equally as kind of more physical health benefits in our system. And so we see this lack of parity there. All right, folks, that's all I have. So my